Hey guys, we're going to take a few minutes and talk about point of care ultrasound for cardiac tamponade. So, what is cardiac tamponade? And is it a clinical diagnosis? And if not, what are the echocardiographic findings in tamponade? Specifically looking at what happens to the chambers of the heart, what happens to the IVC, and then looking for echocardiographic findings of pulsus paradoxus. And we do that by looking at the mitral valve inflow blood velocity. And then just some troubleshooting, which is not very relevant to our SonaGames prep. So what is cardiac tamponade? Basically, you guys know it's an abnormal accumulation of blood in the pericardial space, which causes compression on the cardiac chambers and therefore a reduction in cardiac output. It happens on a continuum from mild, moderate to severe, and size doesn't matter. It depends on the rate of accumulation of that blood in the pericardial space. When it's severe enough, the chambers equalize their pressure and the pericardial pressure overcomes any of the interchamber pressure, causing hemodynamic collapse. Very bad. Not good. So is it a clinical diagnosis that we learned in school? Remember Beck's triad? Muffled heart sounds, JBD. Yeah. Hypotension, I think, was the third one. That it's a late finding. You don't want it to lead to that, right? So the echocardiographic findings are actually seen before Beck's triad, before these clinical signs. So this is important. You want to look for all the signs we're going to talk about. The more you find, the more severe. So what happens, I guess, first? What is the first finding? Well, chamber collapse. And it occurs in the most compliant area of the heart where the wall is thin. So that is the right side of the heart. Left-sided findings occur later. So the right atrium in systole is, if you have the right atrium collapse in systole, that is the earliest sign. So why is it systole? Well, during systole, when the bottom of the heart is squeezing, the right atrium is relaxing. That's when the pressures are low to allow it to fill, and that's when the pericardial pressures from that fluid in it, if you have an effusion and leading to tamponade, it squashes the right atrium when it's relaxed. Then you see right ventricular diastolic collapse. So when the right ventricle is relaxed, when it's filling, and if there happens to be tamponade, that's when it'll collapse. So just remember, if you are trying to see if there's tamponade and you see some chamber collapse or something funny and you're not sure what you should be looking for, just think, when is this part of the heart in its most relaxed state? Okay, because that's when it's most compliant, and that is when it is most prone to collapse from outside pressure. Here's a nice little example. So this is an M spike placed over the heart in the parasternal long axis, and it's placed right at the tip of the mitral valve and the right ventricular free wall, so that wall right closest to the sternum. So as the heart is beating, that mitral valve is opening, closing, coming, anterior and a little bit more posterior as it closes. So when it's open, it deflects up towards the more superficial, one of the parts of the heart, towards the sternum, and that is the E wave. So early diastolic filling, it pops open, and then you get a little A wave or atrial kick. So that E wave is a start of diastole, right? When it's open, when the ventricle's filling. So we want to see if that right ventricular free wall is collapsing when it's the most compliant, right? During diastole. So during that E wave, early diastolic filling. So that E wave, you're going to basically draw a line up to the free wall. All right, and you can see that over in the right-hand column where the right ventricular free wall is. It's at about 4 or 5 centimeters in depth. Is it collapsing? Not necessarily. Well, actually, I lied. It does look like it's collapsing. When I looked at that second E wave, I actually see it collapsing. Interesting. Oh, and it says tamponade anyway. So yes, I hadn't looked at this in a while. Yes, it absolutely is collapsing. You see that negative deflection. And then at the early or late after the atrial kick, it starts to rebound. Right, there we go. That's the right ventricular free wall. So, RV collapse and diastole is probably the easiest to evaluate, right? Is it collapsing when it should be actually filling, right? When it's relaxed, when it should be filling with blood. Here's another great example. Hopefully you can see this. You see the mitral valve down there, more towards the bottom of this waveform. And as you draw a line straight up to the RV free wall, it is pretty evident that is a negative deflection. So as the mitral valve opens, that positive deflection up, it pops open, the leaflet moves more anterior. Then we draw that line towards the top right ventricular free wall, and it is clearly collapsing during diastole. Very specific, about 75 to 90%. Oh, this is interesting. Severity of tamponade correlates with the duration of chamber collapse. Another thing you can look at is the IVC. It's not very sensitive for a bunch of reasons. It could be plethoric, right? We know that. There can also be individuals who are actually fluid depleted, volume depleted. So normally you would see a plethoric IVC if there was tamponade, right? There's extra pressure in the pericardium, and that is causing increased pressure in the SVC and IVC as well. So as we evaluate that, we need to just keep that in mind. That is not super sensitive. So a big chunky IVC greater than 2.2 centimeters with less than 50% collapse and effusion, and you see some RV, RA, or even left-sided chamber collapse, you should definitely be concerned. But if you are still having these chamber collapse without IVC plethora, I would still be concerned. I actually did have a patient who was severely dehydrated and still had tamponade. Her IVC was very small, greater than 50% collapse. It was very thin, but it was quite obvious with all her other findings. She was experiencing cardiac tamponade. And that is actually, called low pressure tamponade, something to remember. Another finding in cardiac tamponade, there's echocardiographic findings of pulsus paradoxus. So if you recall, pulsus paradoxus is when there's an exaggerated drop in blood pressure during inspiration. So this is actually an infographic or kind of a drawing. So during inspiration on the right, usually you take a deep breath in, your intrathoracic pressure drops to allow blood to flow back to the heart, right? And as the tricuspid valve inflow increases, that blood returns to the right side of the heart. And actually, because there's this increased intraventricular dependence, right, from all that pressure in the pericardial space, that extra blood flow back to the right side of the heart compresses the left side of the heart. Plus, the pericardial fluid compresses the left side of your heart, and your blood pressure drops. During expiration, it kind of flips. So the mitral valve, the left side of the heart, pressures increases, more blood flow, and it kind of squashes the right side of the heart, decreasing preload. Yeah. So this is a great example of pulsus paradoxus found on your ultrasound or your echo. So basically, you're getting a 4-chamber view, so an apical 4-chamber, and you're throwing. You can put color flow on it. That's great to ensure that you're in that mitral valve blood flow kind of jet, and you're going to see this E wave, A wave, E wave, A wave pattern like we discussed before. So the E wave is early diastolic filling. So blood is coming from the atria into the ventricle. And then you see these little A waves. So we really don't care about the A waves. So we could just go ahead and get rid of those. We care about the E waves, okay? Now the E waves are what we care about. And from the tall, and you don't even have to know if they're inspiring or expiring. It depends on the difference between your tallest E wave and your smallest E wave on the mitral valve side. So if the inflow velocity, if that change, so tallest minus smallest over tallest, if that's greater than 25% on the mitral valve side, you're concerned for tamponade. If you're going to do the flip it and put it on the right side of the heart and look at the tricuspid inflow velocity, if the tallest E wave from the smallest is greater than 40%, that is concern for cardiac tamponade. Again, you're putting your PW through the mitral valve, right? On the left side of the heart, greater than 25%. If you also got a good view of the right side of the heart, you can throw the pulse wave through the tricuspid valve, and if it's greater than 40% difference between the tallest and the smallest E wave. So large minus small over large. All right, here's another great example. This is 33%. This is through the mitral valve. This is cardiac tamponade. Yep. And these are just some troubleshooting things, more specifically for clinical application in our emergency department, not something you really need to know about for sono games, but sometimes it's going too fast, right? You got to slow down the sweep speed to get more waveforms in your view, so you could just slow that down, get nice E waves, A waves, look at that. Okay, then obviously aliasing can occur. What you need to do is try to increase your scale, so increase the speeds it can visualize, so you could do that with the scale. So remember, cardiac tamponade is an echocardiographic diagnosis. You want to catch it early before clinical signs and symptoms occur. Remember looking for chamber collapse. Right side occurs first. Throw the M mode on to look for pulsus paradoxus. Take a look at that IVC, but don't be fooled by it because it can sometimes be skinny in low pressure tamponade. And adjust your settings as needed.